TNT Open Mind Insights brings you powerful, authentic conversations, illuminating the path to better mental health care for all.
So, welcome, Dr. Heinrich. It is so exciting to speak with you today about mental health and to learn more about your journey and kind of the challenges that people are facing and how you hope to help people in our community. So, welcome to the conversation. Thank you so much for joining us.
Well, thank you for having me. Thank you for allowing me to talk about this important subject. I look forward to it.
Yeah, so first, I want to just kind of talk about what are some of the challenges and difficulties that people are facing that you hope that your work will address.
Well, that's a big question because that really does run the gambit, right, of what people are facing today. I mean, we're dealing with a lot of stuff in today's society. We're dealing with, kind of the straightforward mood disorders like depression and anxiety. We're dealing with socioeconomic issues that we're facing with our patients. Really, there's just so much out there, right? I mean, that's half of the issue.
What are the types of issues that kind of keep you up at night or really get into your head as far as like, I wish that this particular one I could solve?
Well, I mean, again, as somebody who's dual boarded in family medicine and psychiatry, one of the issues we often confront is how society, how payers like insurance, and even clinic administrators and hospital administrators look at the mind body connection. They tend to look at it as the mind's over here, the body's over here, and they're not connected. And one of the things you quickly observe when you practice medicine is that dichotomy is entirely false. The mind and body are connected. There's kind of a famous saying, there is no health without mental health. That's so true. So that's kind of one of the bigger things I see is trying to take that false dichotomy of the mind as being different from the body and bring it together in regular practice.
And that really is reflected by the fact that you have two specialties.
It doesn't hurt. No, I mean
Yes.
you in medical school, you quickly, in medical school, you're divided into these groups that are interested in behavioral health and the other group of medical students that really are not. And you don't begin to appreciate the importance of connecting those two and the importance of comorbidity or co-occurring illnesses in our patients until you're confronted with it clinically, until you're sitting in the exam room in your family medicine clinic with a patient and you see this interconnectedness. Um, so it was during those times in my education that I really began to appreciate that importance. And I was really fortunate. I was very serendipitous that um, these combined residencies were just approved, and I was actually able to do a combined family medicine and psychiatry
Oh,
residency.
combined.
Yeah.
Oh,
So I
okay.
didn't have to do two separate. I did
That's
them both at
good.
the same time. So
Yeah.
5 years instead of, yeah.
But you started off in sorry,
No,
with family
you do
medicine.
them. My interest originally was in family medicine. So early on in medical school, that was my role model, right? Was my family medicine physician as I was a kid growing up. And I even signed a contract in medical school. I was so committed to doing family medicine. I signed a contract committing myself to practice family medicine in Wisconsin.
Oh my gosh.
And it wasn't really until, again, that kind of clinical experience, of being in the provider role, that I began to appreciate the importance of that comorbidity. And I had a mentor who was lucky enough to be in the know that said these new unique residencies are starting up. Would you be interested in doing one? And I very much was at that point. So
Yeah.
it was pretty cool.
So was there one moment that you can think of in your journey where you went, "Oh, I have to put this together."
Yeah, I mean,
Tell me
truly,
about it.
yeah. So, as a medical student, at the end of one of my clinical years, I was fortunate enough to rotate on an inpatient psychiatry unit, and on that inpatient psychiatry unit was a pregnant woman who was suffering pretty severely from her psychiatric illness. And I remember reviewing her chart and talking to her and hearing about her story. And it was that lack of, I mean, she'd had almost no prenatal care.
Mm,
And then and that was the acute issue. But if you delve deeper into her story, she really hadn't got any health care for a long period
mm,
of time before coming into the hospital. So her story, her pregnancy. She was in the hospital long enough to actually deliver, so I was actually able to be there for that as well. Um, Really got me interested into the family. It got me interested into the importance of caring for that whole person.
Wow. So you saw how those two interrelated
Yeah.
with her.
Hmm.
Yeah. I wonder if she knows how she changed your life.
Yeah,
Probably not.
yeah, that's one of the positives and negatives about like the rotations. You're kind of there with the patient
Yeah.
and then you disappear. So no, I don't know if she knows how much she meant to me in my professional journey now 25 years later.
Yeah, it's so funny that we'll never know sometimes how we affect people, huh?
Yeah, it's true.
But like that kindness, it's never wasted.
No.
Or those connections, I should say.
Well, kindness too. She was willing to tell me her story, right? She didn't have to do that. So I thought that that was really, really valuable for me.
Yeah. So why medicine? Why taking care of people? Why did you choose this field?
Yeah, I mean, it's great. I mean, who wouldn't want to do it, right?
Lots of people.
Yeah, no, I
But
say
you chose
it
this.
really wasn't a question. It was
Okay.
something that I just have always, like I mentioned, my primary care doctor growing up. I was fortunate enough not to be ill, but still, I really enjoyed my time with him. I enjoyed working with him. I enjoyed my conversations, just visiting his clinic. I still remember visiting his clinic.
You enjoyed going to the doctor
Yeah,
as a kid?
as long as there wasn't a shot involved, I think it
Yeah.
was okay. But yeah,
That's usually how that goes.
no, it was just kind of it was fun to just talk to him. Again, not being sick, there wasn't a lot of time spent talking about my symptoms. It was, what do you want to do when you grow up? And I want to be like you. And he would sit down and
Oh, that's
kind
cool.
of tell me a little bit about what it was like to be a physician and what medical school was like. So, um, yeah, it's always been an interest, even through high school and college. It was kind of a one direction course for me. I was fortunate in that.
And then going through your training, discovering psychiatry, and then deciding to specialize in both family medicine and psychiatry
Yeah.
together.
Yeah.
And then and then what happened? Like we don't have to go to through every piece of your journey, but how how have you been working to be an advocate for more mind body
Yeah.
focused approach?
Excuse me. You know, that's an interesting story because it's actually changed pretty significantly from being a resident and working in a primary care setting and seeing those what we call ambulatory, the patients that are kind of walking into your clinic and walking out of your clinic. Um, and then as the residency began to progress, I recognized that same mind body disconnect that I was seeing in the outpatient setting, in the inpatient, in the acute care hospital setting. So, patients coming in after a heart attack or with cancer or congestive heart failure, they were acutely ill, but they were suffering the same disconnect from behavioral health and mental health as my patients in the ambulatory setting. So I had kind of an epiphany at that point from a career standpoint is I wanted to look at improving that connection, that mind body connection in the inpatient hospital setting, the medical hospital
Hmm.
setting. So that's kind of that was the next stage of my career is looking into how can we connect acutely ill medical and surgical patients to the behavioral health that they need
Yeah, how can you?
by being there, right?
Okay.
It's being available and being there. It's demonstrating efficacy, but it pretty much comes down to the idea, very much like in an outpatient practice, is being there and being open to their stories, hearing where they're at, and hopefully helping them get through that rough patch.
Mhm.
And
Mhm.
sometimes is talking to the patient, sometimes that's medication, sometimes that's both, sometimes it's just holding their hand and sitting at the edge of the bed and listening to them and being there with them and their families.
Which is hugely important and impactful,
Yeah.
but not necessarily a systemic offering.
Yeah, I mean, there's some interesting work going on in trying to make it systemic, and that's
Okay.
kind of really, really exciting. Historically, now we're just on, so this is when we think about behavioral health and physical health. We really need to think about how best to bring those together, and some of the ways to do that is by screening. You're working with patients in a primary care setting or again in the medical hospital, but they're there for a reason, but there are often other things that are complicating the picture that you may not have time in a 15-minute visit.
Mm.
So, by screening before the visit, bringing those issues up, prompting the provider to have those conversations with the patient, um, you can really systematize addressing behavioral health issues,
Okay.
both on the outpatient side and on the inpatient side. And then once you systematize identifying the behavioral health issues, then comes the fun part of designing a system to address those behavioral health issues. And that's a lot of fun, and that's a lot where my career has gone to date is kind of finding those, building those systems, finding the issues and building the systems to address those issues.
Oh my gosh, this is so exciting.
Good, somebody else likes it.
No, it's awesome because I feel like, in the work I've done as a storyteller, I'm really interested in using my work to promote healing in communities. But it feels a little amorphous sometimes, like how to, sometimes people care and sometimes they don't, and some people heal and sometimes they don't. And I'm not a scientist, but when I hear about people that are scientists that are studying, like, we're going to find out what's working and how we can systemize it, that gets me very excited because then we have the ability to affect more,
Yeah,
you know.
right. You get these ideas, you have a gestalt, you have a feeling that they're going to help people. So you build a system and then you monitor the system, you measure the system, you measure the system's impact. Once you have that data, that allows you to disseminate it to have a more positive impact across many other people's lives. You know, it's not an uncommon question is like from a primary care provider, why am I the one managing all of this?
Ah,
You know,
I know.
why am I the one that's got to do the diabetes and do the high blood pressure? And now you're asking me to manage their behavioral health conditions like depression or substance use. And the family medicine physician in me is like, man, you're the best person to do
Yes.
this.
Uh-huh.
Not the psychiatrist. You're the one that you have the population of patients, so you can do that screening and impact the greatest number of patients. But then, and most importantly, you have the therapeutic relationship and that patient's trust to get them to talk about the screening that was just done that raised a concern of depression, raised a concern of trauma.
Mm-hmm.
And you can have that conversation and you can make a diagnosis. And most primary care doctors are so willing to do that if they have the backup and the
Yeah.
skill set to do it. And that's just truly important. But then once they make the diagnosis, rather than ship them off to see a psychiatrist and repeat everything, you now have the ability to use that therapeutic relationship to talk about the next step, the treatment. Is it going to be talk therapy? Is it going to be a
Mm-hmm.
medication? And you can initiate that. And
Yeah.
then because of that longitudinal relationship, you can follow them and see that
Yeah.
what you did
Because
is
they keep
actually
coming.
helping.
Yeah.
Yeah, because
Yeah.
they keep coming back. It's natural. So I think primary care providers are uniquely set up
Mm-hmm.
to manage these for that kind of longitudinal relationship and that longitudinal therapeutic relationship
Yeah.
that they have.
And nurse practitioners too.
Yeah,
And I've
right.
also there seems to be more culturally competent or diversity within those providers as well, as opposed to the psychiatrists available, to
Yeah,
be honest. Like, I've spoke with fellows that, they're uniquely positioned to address the needs of their own community,
yeah.
um, that you just wouldn't know what they're going through unless you were part of that community.
Without a doubt,
Yeah.
without a doubt. And it's yeah,
Yeah.
but
So this is exciting. So you said, like, once you identify the 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 issue or the challenge that people are
mm.
facing, then you can systemize an approach to it. What are some of the approaches that you're looking at uh, that may have effects in that setting?
Well, I mean, one of the more impressive ones in a primary care setting is called collaborative care, where You take a very population health approach to a condition, whether that's depression, anxiety are the two more common ones, but it can be done for substance use as well. So you take that population health approach by screening an at-risk patient population, hopefully identifying the condition in a patient population, and then supporting the primary care doctor through the manage of that through a very kind of evidence-based stepped care approach. We guide you from an evidence-based, what's first line. We guide you, if that doesn't work, what's second line and what's third line. And then we tell you when, you've done what you can do here as a primary care physician, and maybe now it's time to bring in some subspecialty help. But what's really unique about the collaborative care model is it brings a team approach into that management. It isn't just the primary care provider
Mm.
on an island.
Hmm.
There's a care manager that actually is kind of the linchpin for the whole system.
Hmm.
They are the ones that contact the patient. They do the measurement of the patient's symptoms and in alignment with the patient. They communicate those findings to the primary care provider and to a collaborating psychiatrist who helps kind of appropriate, kind of guide the appropriate treatment and allow the primary care doctor to follow those recommendations. So again, primary care provider, APP, physician, kind of is that captain of the ship along with the patient, but the psychiatrist can provide necessary input at kind of key moments in that patient's
Hmm.
care.
Yeah.
Um, so it's kind of the best of both worlds.
Is this a new approach?
It's been around for about 15, 20 years in the literature, amazingly evidence-based, um, but kind of slowly kind of growing out throughout
Yeah, because
healthcare
I haven't
systems.
heard of it
Yeah.
or I haven't experienced it.
It's really a chronic disease model
Okay.
that they've been doing in diabetes and congestive heart failure, but taking that chronic disease management model and bringing it into behavioral.
It sounds really helpful because it connects things,
Yep,
which is your whole goal in the first place,
exactly.
is to connect it.
And what's really amazing is some studies have been done that have looked at that, and if you address their depression, their their medication adherence for their antihypertensive medications gets better. Their diabetes control improves. So it's again, it's that mind-body connection, right? You address what you can through these kind of
Hmm.
systemized approaches, and you can see a lot of unexpected consequences.
Hmm.
So,
So
well,
this
not
feels
truly
like a
unexpected, but
little bit of
pleasant.
a chicken and egg question, but which comes first? Is the mind affects the physical body, the physical body affects the mind, or does
And
it go both
I
ways?
think it really does go both ways, and we see that. I mean, there are studies that demonstrate that um, patients with, let's pick diabetes, patients with diabetes are at a higher risk of developing depression. But then
Hmm.
you have patients with depression who are at a greater risk of developing diabetes down the line. So there
Hmm.
really appears to be a bi-directional relationship for at least depression across a couple of conditions, diabetes and heart disease being the two best studied.
Yeah, that
So,
makes sense.
yeah.
That makes sense. So, what do you do personally for your mind body connection?
Um, I think a lot of it comes to having a good support system, family, great friends. I have my friends that do what I do, so it's often nice to have those conversations with them about kind of the daily grind, the daily aspects of medicine that only they will understand. So it's nice to have those individuals. Interestingly, not a lot of those are in psychiatry or primary care, but it's still nice to have those conversations. And then I think it's important to have friends and family that don't do what I do at all.
Yeah,
And
absolutely.
that's just so that's the primary is kind of the talking with friends and family. I do think it's important to really look out for yourself with this. It's
Absolutely.
it's it's hard to be a clinician. It's hard to it's amazingly rewarding. It's also a challenge. I don't want to minimize that. So I think looking out for yourself to kind of prevent demoralization and lead that leading into professional burnout is really important. So talking to family, talking to friends, I think exercise is amazingly important. So
Yeah, and this is a real issue for the
it's
providers,
a huge issue.
and
Yeah.
it's just it's kind of sad and alarming because because the providers are caring for other people, and if they're not okay, then that's scary.
Yeah, and I think without a doubt, and I think one of the things that causes a lot of burnout is the provider feeling like they're on an island. I think I mentioned that
Mm-hmm.
before, that all of this is falling to me. All of the care of the patient is falling to me. These administrative burdens, these demands are falling upon me. And I think kind of like that model of collaborative care we talked about earlier, if you can bring a team into it,
Mm-hmm.
that is protective of
Okay.
burnout. You're not alone.
Yeah.
There are folks that are helping you address the patient's condition, manage the administrative burden, and improve the patient's care.
Mm-hmm.
So that's a very rewarding type of practice that really, I think, minimizes the risk of demoralization and eventual
Yeah.
burnout.
I love hearing about that because it's benefiting the patients and the providers. It's like hitting both areas of need
Yeah,
simultaneously, which makes it kind of brilliant.
twofers, right? We like
Yeah.
twofers.
Yeah, exactly. So what's stopping us from making this, the model,
Yeah.
like across the system?
Yeah, sometimes it's just it's buy-in. People don't like letting go of patients, so part of this model is you have to trust your care manager and the psychiatric consultant to really help kind of guide their care. And some providers really like to continue to hold that closely. I think a more fundamental issue, and this is a little bit harder, is kind of there's an administrative leg. There's a resistance to kind of changing the status quo. There's a cost inherent with
Mhm.
this model, at least initially. The good news is a lot of these models can actually pay for themselves once they're up and running. But until it's up and running, there's an investment.
Hmm.
So you really have to work with administration, work with leadership, work with the clinicians on the ground to really, I want to say sell, but sell this kind of evidence-based model of care. Once they have it, they never let it go. Yeah,
Yeah.
it's really impressive to watch when it takes into a clinic and just see the buy-in. It's pretty impressive.
Wow, that's awesome. And then you get more evidence
You get
that it
more
works.
evidence and word of mouth. Don't
Hmm.
underestimate the power of word of mouth. As one provider in one clinic had it, and then he or she needs to move to the next clinic, and they're like, "Why don't I have this here? This was amazing."
Yeah,
Yeah.
yeah. So then, okay, so that's one way, word of mouth, but what are some other ways that are looking to spread this model?
Data. I mean, I think it's really bringing the data to administration. We were able to grow where I practice our collaborative care model by being able to demonstrate cost effectiveness
Yeah, yeah, that
by
speaks volumes.
yeah.
People are always looking to
Yeah.
save
We
money.
were we were able well, yeah, it's cost effectiveness in that patients were getting the care where they needed to get the care. We were able to demonstrate that patients with depression weren't presenting to the emergency room,
Mm.
weren't being admitted to a medical service unnecessarily. So we were able to show decreased emergency room visits and decreased medical hospitalizations as a result of addressing their depression and anxiety.
Oh my
The
gosh.
savings induced in those decreased admissions and presentations to emergency room were more than enough to offset the cost of expansion in our setting. May not be the case for everywhere, but it was in ours. And then you add you see better outcomes. You see, we actually studied this. We looked at the how depression resolve the rate of resolution of depression in patients that were enrolled into this program and patients that weren't enrolled into this program. And we saw greater than 50% reduction. I mean, greater than 50% difference in those two. So the data's there.
The data's there. I love that. You got the data, then you just got to get people to hear the data and do that initial
Yeah.
change, right? And then it's kind of off and running.
Mhm.
Is this something that's being considered outside of the United States as well?
I believe so. I'm not very familiar with the data outside
Okay.
of the United States, but I do believe there's no reason why it can't be done.
Hmm.
But it's definitely being disseminated across the U.S. And there's just a lot of resources out there. So people that are interested in doing these types of work, there are resources out there from the federal government, from the University of Washington has a organization called has a center called the Ames Center that is a wealth of information on how to really it's kind of a, what's it called, turnkey, kind of
Mm-hmm.
really gives you all of the information you need from the beginning to start those conversations with administration and with your physician collaborators to really get it through the entire system to up and running. It's really impressive. So it's evidence-based, and there are ways to kind of guide you through the implementation of these programs.
Yeah, you guys have thought of everything.
They thought of everything. I use their tools. I mean, really,
Yeah, yeah, that's really hopeful though.
it
I
is.
feel like it's really hopeful. What are some of the just like major things that you've learned in this work that you would want people to know?
Yeah. I mean, it's very similar to what we started with. It's that connection. It's the importance of looking at a person as a whole person, not just the mind, not just the body, but together. And then to take it even one step further is looking at the environment surrounding them, kind of
Mm,
the socioeconomic kind of approach to what's going on, the cultural aspects of what's happening. I think the broader our lens as we look at a patient, the better service we give the patient, the better outcomes we can expect. That's kind of the take home. And it's not only limited to the ambulatory outpatient setting, but it's also important when somebody gets really sick and ends up admitted to the hospital. That broad lens, that broad view of the patient and what they're going through at that moment is really key.
wow. Yeah, and it does feel like maybe it's a little more complicated to look at it that way. Do you feel it's a little more difficult to look at it that
You
way?
know, you'd think, but I think if you build the systems in place that help you look at it, it makes it a lot easier. You don't, again, the team-based approach, you don't have to do it all.
I see. Yeah. Okay. I
There are
figured.
ways that you can build systems to help you identify that and allow and help you address the issues that are identified. So it can be a challenge, but it doesn't have to be.
Yeah, I like that. So you're not in it alone.
Not in and alone. That's
So
really
we're
key.
asking you to look at a bigger picture, but you're looking at it with other people
Yep.
to give insights.
Right.
Ah, that is so cool. That is very cool.
Mm.
Well, it gives me a lot of hope. What does the future look like to you?
I think it's looking really good. I think as we in medicine begin to focus more on outcomes, I think the ability for us to push the importance of the mind body grows. Um, and it really allows us to demonstrate our value to a patient, our value to a clinic, our value to a healthcare system, and our value to a community. So if we're able to demonstrate that, we're doing good. And I think we're getting there.
We're getting there. Thanks to work from people like you and your colleagues and
Mm.
the TNT program and everything else.
It's a
It's
lot of
like
fun. Yeah.
all bringing it all together.
All bringing it together.
Amazing. So if somebody wanted to connect with you, learn more about what you're doing or ask you a question on the side, how might they get in touch with you?
I'd be happy to talk to folks. The best way to reach me is through probably my email through work at theinrich, THEINRIC at mcw.edu.
Okay, great. And we'll put that in the notes for the program.
Perfect.
So thanks so much for talking with us. We really appreciate it.
I appreciate the time. It's been fun.
Yeah, wonderful.